All right, in this video, we're going to go over some tips for charting specific to the emergency department, which can be a bit different than your classic SOAP note. As with everything in the emergency department, your charting is going to relate to emergencies. So obviously, everyone's going to adopt their own style, but of course, the core is going to be the same. But the biggest difference compared with other specialties is the exchange of the assessment and plan for your medical decision making, which I'll explain in a bit. All right, so here are some quick tips for your HPI, which obviously you can just read through. The first one being pretty self-explanatory, but let me explain the second one a little better. So, group pertinent negatives based on possible emergencies related to your chief complaint. This involves helping you rule out your emergency differential. So I like to think of those red flags for my emergency conditions and then ask the patient about them. And then obviously if they don't have them, group them together in your HPI so that anyone looking at it will understand that you've thought about the differential. So in this example with someone with a headache, the first denial grouping statement clearly states you were thinking about a subarachnoid hemorrhage, right? But the red flags are absent. The next one, fever, stiff neck, vomiting, well, that's talking about meningitis. And then lastly, sometimes you will not agree with nursing documentation. Actually, this happens quite a bit. For instance, the nurse might document that the patient has chest pain, but then you talk to the patient and they say there's no chest pain. And it's totally okay to disagree, but you should mention it, because if the nurse documents it and you don't address it, then that looks bad if the case ever gets reviewed. So as an example, you could say, despite what the triage note mentions, the patient states to me that he is not having any chest pain, and that would be perfectly appropriate. All right, so now we're going to get into medical decision making, which again is specific to the emergency department. Basically, it sums up the emergency department visit and it explains your reasoning for why you did what you did or why you didn't do what you did not do. So anyone reading it should be able to understand what happened to the patient and why. And as a side note, some people do think of it as a defense if the case ever gets pulled for review. It's basically your deposition as to why you did certain things. So for example, did you have a good reason for not getting a CT on a patient with a headache? This would explain your reasoning. All right, so here are some suggestions on what you can actually include in your MDM. A lot of students do struggle with this when they first start out just because it's new. It seems intimidating. You don't really know where to start. Again, everyone is going to take on their own style. Some are going to be longer. Some people are going to have shorter MDMs. But these are the basics that I personally like to include. So you're going to talk about why the patient came in, what diagnoses you considered, what you gave the patient, and where you sent them. There is a note about people going home getting longer MDMs, and that's generally because you have to be a bit more defensive about why they were safe to go home. And then lastly, address any abnormal vitals. So for instance, a patient has tachycardia, and you could say you suspected secondary to dehydration, it improved with fluids. It lets the reader know that you thought about the abnormal vital and did not just ignore it, and that you actually have a reason for it and that you're okay with it. Here is a gift for you. I put a very basic sample template that you can follow for your MDM when you first start out. It's definitely not going to work for every patient, but it is a good starting point when you have no idea how to start these. And then on the next few slides, I also put some examples for you to see how things change based on the specific complaint. So obviously I'm not going to read this out to you, you can read it, but I do think this will help you when you're starting out. Here's your first example you can read through. It's about a 13-year-old with pharyngitis, talking about the emergencies you considered, why you think it's one thing or the other, and then what the plan is. Definitely read through it, and if you have any questions, reach out to me. Here's an example of another discharged patient, this one being a 23-year-old with an ankle sprain. You can read through it again and see how it changes based on the complaint. If you have any questions, obviously reach out to me. Now finally, I tossed in an example of someone who was admitted. This I really put in because I want you to see that the template is not always perfect and you do have to adjust it based on the patient. Also, admitted patients tend to have shorter MDMs, which again, you can read through this. Obviously, depending on your patient, this is going to be completely different, but I just wanted you to see at least one example of someone who was admitted.